Good morning and welcome to session number 32. I am Samir Mehta from the broadcast studios at Mount Sinai Heart, taking you through another genuinely challenging complex coronary intervention. This is also a landmark session for us as we begin today our Chinese simulcast translation. I am delighted to welcome Una Wong, who's with us at the broadcast studios and who will be taking you through the translation. To our Chinese colleagues who are joining us, go to the home page. There is a link there to the Chinese live stream. Please click on that and you will see us live all over the nation of China. Delighted to welcome Dr. Hongbing Yan at Fuwai Hospital as well as Dr. Yong Hoyo at Peking University. Hopefully your team is there and watching our live cases. Also delighted to welcome Amy Hogg at Bangkok, who's going to be coordinating numerous Asian physicians to our show. Without any further delay, we have an exceedingly difficult and complex case which is going to require a lot more dedicated time. It's a CTO. Samin, good morning. You are all ready with your team in the cath lab?
Yep, absolutely. Good morning. And as you said, that another historical moment for us in terms of adding the new to our CCC Live, that is the China, and of course next one would be, we have spoken about whether to make it for a Japanese or South America or so, but we'll continue to add new languages. As you said, it's clearly a very challenging case, and I'll present a little data on this case quickly, and of course welcome all our audience and new viewers from China. This is a case, is our case number 32 as you mentioned. It's a patient with prior bypass. The patient has a LIMA to LAD and SVG to RCA back in 90. Then he had a small MI, had a small, at that time in 2003, had a circumflex which was not bypass, had a stent, and now presented with class 2 angina and has a stress test which revealed septal and inferior ischemia. Now cath was done last month, which revealed 3 vessel disease with patent LIMA to LAD, occluded vein graft to RCA, patent DES in circumflex with a small OM to occluded, normal EF, but more importantly, the totally occluded right coronary artery, which will show you fills by antegrade collateral as well as collateral retrograde by a large first septal, which had an 80% stenosis. Therefore, now we knew why ischemia was positive in 2 areas of the septal and inferior, because of that septal stenosis and occluded graft to the RCA. So we felt maybe since RCA is very challenging, which will, as I said, I'll show you, we said maybe we put a stent in the septal ostium and see how patient does. So that's what we did. We put a Science V DES in the septum, 2.712 millimeter, and patient good medical therapy as shown here. Basically continue to have class 2 angina. And we added already isosorbide mononitrate, despite he still have his unchanged symptoms. So that basically we are not repeated the stress test because symptoms are there, but septal stenting did not help much. So with that note, I'll ask Anu to show this angiogram right from the beginning now.
So we already have a dual injection. If you see from the on the left side, we were injecting on the left coronary artery, which is a 5 French diagnostic catheter, and on the right side of the patient, which we are using the guide catheter going to the right coronary artery, we have used a LIMA guide with side holes. Patient creatinine is okay. If you see, first what you do is you inject the left side, you see the collaterals, and then you inject the right side. It's a short, maybe a 15 millimeter CTO. But why is it so challenging is it has all the negative features for the CTO. There is a side branch, and more important is at the level of the occlusion, it is a wide base. It's not tapered, wide base, so we don't know exactly at what level we have to start penetrating this or even the drilling in this particular part of the CTO. That is why it's very challenging, because you can see it is almost a 5 millimeter wide base. So you could go to any part, keep trying to see if you have any microchannels. Likely, though it's more like bridge collaterals rather than microchannels, and that's why the wire use in this particular case would be challenging.
Yeah, and you see that it's a mega right corner. Look at how big the right is.
Any comment, Samin or Anu, about the fibrous cap, which you'll probably need to address there?
Well, I think it's a very, very thick, fibrous, blunt cap. And what has been shown, the whole concept of the retrograde is, while the antegrade cap is very horizontal and blunt, the retrograde cap is funnel shaped. And I'll give you some schematics.
If you can see here, actually, if you see the retrograde is tapering.
Tapering. So that
it is the antegrade blunt.
That if we need to go through retrograde, we need to go through retrograde may help. So therefore, again, based on the OCC criteria, and I'll talk about this, what has been changed, that we put this patient into a class 2 angina, intermediate risk scan, and maximum medical therapy, so they're appropriate to intervene. Now, taken the points which are very important from Dr. Anu point of view in terms of these cases with the guide wires and guide shaping, and she'll actually talk about, because she's our expert in the CTOs, that how do you go to the escalation of the guide wires and shape the tip, which as the case will progress, and of course the new support of these catheters.
So since this is mid RCA, the question always comes, how do you reach the CTO? So to reach the CTO, always have an support catheter, which could be your fine cross, or you can use over the wire balloon system, whatever that is available. So a fine cross actually has a lower profile. Use one of those, and what you do is use your regular workhorse wire, or you can use the glide coated wires. So in the glide coated wires, you actually have from the Asahi 3 wires, which could be fielder FC, and fielder XT. So why they are called glide wires? Because they have a polymer coating as well as a hydrophilic coating. The two makes them very slippery, so you got to be very careful. We tell the fellows when they start, it's like a snake. Before you know, it's not that your hands know where the wire is going, the wire tells you where it's going. So you got to be very careful with these wires, that they can go to all small channels. So the regular fielder has a tip that is not tapered, and the weight is about 3 grams, 3.5 grams. Now what's the difference between fielder and fielder FC? Again, not tapered, but the tip has a lighter weight. So what happens if you're doing this very helpful, especially if you're doing a retrograde approach, because the tip has a lower weight, it able to go through the septals or other channels to get through the retrograde area. And what is fielder? XT is exactly like fielder. Again, there is a coating of polymer as well as a coating, and it is a tip that is tapered, which becomes 0.009. Very helpful to find microchannels in this kind of situation. So what we would say, use your fine cross or a support catheter, go up to the area with any regular workhorse wire or fielder wire. Once you reach there, use these glide wires, either regular fielder or fielder XT, to see if there is any microchannels, so that these wires can find their way through. Many times you don't need these aggressive wires. You may just be able to cross with these softer wires. They are also useful if you have created multiple dissection channels, and it's to slide through the dissection channels, we can use the same wires. Then you have your wires which are used to cross the CTO, where you have your miracle bros or you have your confianza. So the miracle bro, the important thing is they are not coated, and the tip remains it's 0.014 even up to the tip, and they come with various numbers, 3, 4.5, 9, and 6 and 12. So with these numbers, it's actually what happens is the weight at the tip of the wire. That is why they given various numbers, but weight is not exactly, actually 3 is 4.5. The more important would be the confianza. So you have confianza 9, and then you have confianza pro 9 and a confianza 12, which is also a pro 12. The pro part of the confianza have a coating at the tip, and this is a hybrid coating, not exactly a glide coating, but it is a hybrid coating, which the others, the miracle as well as the confianza, regular 9 do not have they do not have any coating, so you have a good tactile sensation of the tip. The confianza also has a taper, is 0.0014 becomes 0.009. So go to the next slide. Then the newer one which that has been just has come out, and this is the wire that is also being tested in the expert CTO trial, is the Progress guide wire, not made by Asahi, made by Abbott, and every technology that I have discussed so far has been incorporated into this wire. So the body actually has hydrophobic coating, and if you see the distal 30 centimeter is further divided. 5 centimeter of the tip is a coil, and that 5 centimeter can be tapered anywhere between 0.0014 to 0.0012, 0.0010 becomes 0.009 depending on the various numbers. But what is important is the tip has coating, which is the hydrophilic coating, as well as there is a polymer at the tip. So it's a combination of every wire that we have discussed. It's a combination of the Miracle, the Confianza, as well as the Fielder. Everything is incorporated in this one wire, and what they have actually discussed is the various numbers that come to this wire is depending on the penetration power, and how they have got the penetration power is your tip stiffness, which is the weight at the tip of the wire, divided by the area of the guide wire tip. They have used a pi r squared. If you actually look at why they got the number 40, is 40 grams divided by pi r squared, that exactly gives you a number 1. So they, based on their penetration power, they have given various numbers to this Progress. And very important, why penetration power is important, if you actually see the Progress 140. If you look at Progress 140, if you see the weight at the tip is 12.5, but since it is tapered, you see the penetration power is more than the Progress 120, and that is why if you go to your penetration chart, which you see here, gives you a beautiful idea about the various wires that can be used and the penetration power on the side, and the highest penetration power is actually for the Progress 200, then comes the Confianza. So having this background, how do we go using these various wires is the same. Go with your regular workhorse wire, use your Fielder XT wires, and then start your drilling either with the Miracle, either Miracle 3 or 6, one of the two you try, and then go to your penetration wire, whichever you have, whether you start with Confianza 9, 12 or Progress 120, 140 or 200. And I think this is exactly what we are going to do here. We take a Fielder, go till there, and in this particular case, I think drilling will have no point since it's a wide base. Okay, since we will have to start penetrating right from the beginning to see exactly at which point we have to start getting into the CTO lumen, and also a negative point, since we have a side branch, we may have to occlude the side branch with a balloon. So having these things in mind, we are starting this case, and if we need a support catheter later on, we also have a guideliner ready with us.
Okay. Anu, absolutely excellent summary, a wonderful analysis. It's amazing to see the details and the depth of development which has been required to make these wires. If I was to put you on the spot today and give you, what chance do you think you have of success of crossing it, what would you say, Anu?
That's a good thing, is we always positive. Whenever we go with CTO, always positive and confident that we will get through this lesion.
Samin,
I would say 70% today.
Yes, okay.
If with the second attempt about 20-22% in about 6 weeks if we are unsuccessful, and therefore aggregate will be about 92 to 93% of this CTO, which has been there for 22 years. We have the cath report of 1990. RCA was totally occluded in 1990.
Samin, when you are mentioning a 70% possibility today, look, have you already crossed your 70?
No,
I think in the side.
Far away, no.
We are far.
If it would have crossed, I would have said 100%.
Samin, the question I have for you is that when you are citing 70%, that is mentioning antegrade?
Yeah, actually the key is that and I'll show you in my algorithm, I think antegrade, and then retrograde. That's the way it should be. I think you still have a better chance of antegrade, even if you created a proximal dissection, that during the case you stop the case and then come back and so on. And we'll go through it while Anu is trying to go through, and anytime if she has your crosses, you will stop me, and we'll interrupt our presentation, which will be 10 minutes, so that we'll get ready for our theoretical background.
In the meantime, once again, if you are in China watching our Chinese live stream, please go to the main page and click on the link to the Chinese simulcast. Samin, please go ahead.
Okay. Now we can go back to our slides while we are trying to work out this part. And that will be that two important points: the rationale and technique of CTO recanalization, and second will be appropriate use criteria, the focus update of 2012, which just came end of last month. As you remember, we need to update our viewers with the latest going on. Now we know CTO is one of the most important adverse factor in terms of PCI, and many of these patients go for either CABG or have unsuccessful procedure. So this number actually remains still about 50, 60, 65%. No matter what the data shows, maybe if you are in Japan, where you are trying one lesion for 3 days, maybe your success rate goes 90. But overall, I would say the success rate of the CTO is about 2/3, anywhere between 60 to 70%. Now, adverse factor for PCI CTO, we all know lower success rate, disappointment, family gets upset that we were failed. When I don't remember a non-CTO case, we are telling the family that we failed. That's always the CTO case only. Now, of course, the longer cases disrupt your schedule, more radiation exposure, dermatitis, maybe. Now actually you see the latest paper in Euro intervention talking about the brain tumor for interventionalists. So we need to be careful. We are talking about the patient, even for the physician. What happens? And then of course resource utilization, there is not much reimbursement for CTO, but sometimes you use the multiple long timings and multiple devices. And then minimal incidence but potentially catastrophic complication, thrombus, dissection, perforation, cardiac tamponade, collateral shutoff, side branch occlusion, contrast-induced acute kidney injury, myocardial infarction, urgent CABG. Rare complications, but can occur, and this is where we knew that from Italian registry, that showing that these complications do occur in a very small % of cases, but we always need to think about when we are intervening these cases. Now, then question comes, why to do, we should bother even opening the CTO, because it's not going to cause MI to anybody, because one of the issue is the presence of CTO in a coronary artery disease patient impart adverse prognosis. Now, why do you say that? And second point is because successful CTO recanalization may result in angina ischemia relief, obvious, freedom from subsequent CABG, obvious, improvement in LV function in some cases, yes, and improvement in event-free survival, not necessarily maybe just survival, event-free survival, all makes sense if you succeed. But if you don't succeed, that's where the whole issue comes. But most important is that if you have a CTO, it imparts the adverse prognosis. How? This actually the data from our New York State Registry of the complete versus incomplete revascularization, and you can see that in the incomplete revascularization, you have an unadjusted and adjusted hazard ratio, whether you have one vessel which is non-CTO or one vessel which is CTO, or two vessels which are non-CTO versus two vessels which are CTO. You can see the highest odd ratio, hazard ratio is for the vessel which is CTO. So if you have a patent vessel incompletely revascularized, has a lower hazard ratio of death and MI at a 2-year follow-up compared to if you have CTO. Why? I think likely reason is that the CTO gives the collateral, so that once the collaterals are shut off, that really give rise to a major event. Same data, we actually have the same from the New York State, even in the DES era, that the two incompletely revascularized vessel with CTO has the highest hazard ratio in terms of 18 months mortality. Now, and of course, mortality in MI, so that you can say the patients with the incompletely revascularized vessel with the CTO is the worst long-term prognosis follow-up. Now, also, it has been shown that in setting of the myocardial infarction, that if you have a multi-vessel disease, but with CTO or without CTO, that clearly the CTO, even post-MI, you have done a primary PCI, the follow-up data from this German registry showing that a higher event rate on patients with CTO, even primary PCI. This actually also they showed that if you have CTO, you do not improve your left ventricular ejection fraction in these multivessel disease patients. So therefore, the point is clear that yes, if you successfully recanalize, you remove, you improve many of these symptoms and these findings which I have shown here. Now, the question comes is the DES versus so. The DES is preferred because of high restenosis. And now Roxana, as you know, Mehran with us, she published a very elegant this multi-registry, multinational CTO registry of the cases over last 7, 8 years, 10 years, that overall success rate is 68%. So coming back to the point that if you go to the registry, you go to all cases, your success rate is just in about 60 to 70% range. And also shown that if you succeed versus you unsuccessful, that by succeeding you decrease the overall cardiac death and need for coronary artery bypass surgery. There was no difference in myocardial infarction. So overall success rate of CTO is an important predictor of lower mortality, lower bypass surgery, no difference in myocardial infarction, and actually of the various independent predictor for the all-cause mortality, cardiac mortality, and for patients with CABG, the procedural success of the CTO is a very important negative hazard. That if you succeed, you decrease all of these factors. Now, what do we do? We, besides the wire which Anu showed, that we have few actually devices: the laser wire, the front runner, the safe cross radio frequency, the crosser vibrational catheter, and recently, based on the fast CTO study, the bridge point, the crossboss and stingray devices are available for helping these CTO lesions. And of course, there are many under investigation with the therapeutic ultrasound, the lumen re-entry, penetration devices, vibrational and acoustic devices, and magnetic navigation. And many of these penetration devices, the Turner's Corsair, are part of the expert CTO trial which is ongoing. There are also some concept that in the CTO, giving a thrombolytic or collagenase infusion for a short or long period of time may make the thick cap soft, so you have succeed subsequently. Now, of the technique of the controlled drilling on penetration or sliding, I would say the very simple that sliding is for those microchannels. So the fielder XT, you look for this microchannels which is the sliding. Most of them we use the controlled drilling, and that basically clockwise, anti-clockwise, you pull back and then advance with the support. Penetration is going with the escalation with a stiff wire. Once you need to penetrate the final cap using the confienza, I think penetration is the best for confienza, control drilling for your miracle, and the progress, and of course the sliding technique for the fielder extreme. Now then there are other which I call Japanese specialized technique, because lot of in the CTO field we learned from the Japanese our investigators and interventionalists, because there the idea is to open the vessel and very few patients go for surgery. Anchor balloon technique, the mother and child catheter, and now with guide liner helps with that. The parallel wire, the IVAS guidance, and the retrograde approach. Retrograde approach is a very exciting and actually coming up more and more even in the United States. That is reserved mainly for the LAD or RCA and going through the septal collaterals. Avoid using the epicardial collaterals because that can cause perforation. The second is what are the various techniques? Are the direct retrograde crossing, the kissing wire, we call CARD, controlled antegrade and retrograde sub-intimal tracking, which can be done with a balloon or knuckle wire or the reverse CARD. What are those? If you see here, kissing wire basically means retrograde from the RCA, you are going to the LAD, make a little cap retrogradely, then your antegrade wire goes, and so that kissing wire. Then the retrograde wire cross, that sometimes you cannot go antegrade, so the retrograde wire go all the way. Then you externalize the guide wire into the contralateral guide catheter, and then of course do the PCI. The CART, as I mentioned, that it's a retrograde controlled antegrade and retrograde subintimal tracking. Like the example here from the RCA going into the LAD, you open up the subintimal space, and that helps the antegrade wire to go to the main lumen. And the reverse CART is your retrograde subintimal space opening is not possible, so that you are going antegrade subintimal space, and reverse CART actually may have some higher chance of perforation, but also has been proposed. Now, this basically is the concept of the sub-intimal, antegrade and retrograde sub-intimal tracking, and basically you can see from below that you are creating a space in the sub-intimal, so that gives the lumen a chance with a more penetration by the stiff wire antegrade go to the main lumen and able to succeed. Now, this is the giving example of the balloon or the knuckle wire to create a sub-intimal space. This paper came out as a lead paper last month in JACC intervention. Now, technical issues are very important, that of course they take a lot of time with the guide catheters and exposure, which I have mentioned here. But one of the important point I want to say, that chronic total occlusion indication for PCI are very strict. You can see here lot of I's. I means inappropriate, that unless you can show that patient is symptomatic or have an intermediate plus ischemia, the PCI of the CTO based on the guidelines is not appropriate. So, clearly this case will make it appropriate because of medical therapy and patient has a class 2 angina. Therefore, this is, I would say, the wire technique which has taken part from the paper in terms of the CTO, that CTO-PCI was to go antegrade approach times 2. I said 2 times you try the antegrade, single wire, parallel wire, and of course escalation of the wire technique. If you fail, then of course succeed is good. That I would say with the twice antegrade approach, you probably get 70-75% success. If you are failure, then you go with the retrograde approach, that adds another 20-25. I was guided re-entry, those who are expert and master can use it, but I am a little skeptical. But basically it remains that combining the stage approach in an unsuccessful case will give you overall success of your CTO recanalization. Yeah. Now, very important point which I want to make, that wire perforation during PCI with a CTO is not uncommon, that you will have a small clouds and so, and we actually presented our data of the heparin versus angiomax bivalvular in these patients for the wire perforation, and we found that bivalvular patients who had a wire perforation, they had a benign outcome compared to heparin, and therefore bivalvular is routinely used in our cases like this patient. Now, then second point is appropriate use criteria, focus update, which we have emphasized so much in our all presentations. Recently we got update of our 2009 ACC appropriate use criteria, we call OCC, and actually it's very interesting that did not touch this bar graph or this colored coding graph. So, this is unchanged absolutely. So, that whatever we have been practicing, what are the slides we have been showing for based on these clinical syndrome and invasive finding and vessel disease, this has not changed. What has changed is shown here. One, for the acute coronary syndrome, the patient with unstable angina, some low risk patients have been made uncertain, particularly with the TIMI risk score is 2 or low. And secondly, the patients who did not have a bypass surgery, one of the criticism was almost 30-40% of patients fall into 1 or 2 vessel disease which did not involve proximal LAD, and you did not have a stress test. Now, what you do in these cases? These patients have come to you, 90% mid LAD, there is a 90% RCA. What do? This is still the society of the OCC criteria formulation took a stand that this is inappropriate, because no data in last 3 years have come that your 90% mid LAD is appropriate, and this actually is a part of the criticism. The JACC intervention paper by Marceau and Tierstein this week highlighting that issues with the appropriateness. I still say that yes, you can do it for the symptoms or ischemia, but if you do not have any and patient comes to the cath lab, either you do it by functional FFR, which I would say has come up and may help you to make a decision, but otherwise routine, these patients do very well with the medical therapy. And lastly is for the advanced CAD, and I'll come back to this both the points. And if you can see for acute coronary syndrome, what has been that very simple, the patients who are asymptomatic post MI, they're inappropriate. That's based on the OUT trial. Second inappropriate is doing a non-culprit vessel PCI at the time of primary PCI. After patient is discharged, you do a stress test or symptoms, you bring it back, then it becomes appropriate. So, that basically is the difference in the acute coronary syndrome. Second is very important for multi-vessel CAD. If you recall, in 2009 update, any patient with a left main was inappropriate, actually now they've incorporated the data of the syntax and many other trials, making it left main inappropriate only the patients who are high syntax score of 32 and above. Excuse me. And that is actually the part of our Excel trial also, that patient with a very high syntax score will not be randomized, and only 32 and below will be randomized into CABG versus PCI. So basically what it has done is it has really classified the extent of CAD along with the multivessel disease and the incorporating syntax score in the patient's overall the strategy of sending the patients CABG versus PCI. And I'm very glad, at least from the left main point of view, that we were able to get the inappropriate only in the advanced left main with a syntax score of 33 and above. Now, the second, which I wanted to add one more point, which actually in the document with the PCI guidelines which we showed last month, that they have used FFR very heavily in a decision making. Because of the FAME trial, we learned that deferring the case, we knew the defer trial, and also in the FAME trial that even your angiographic significant lesion, but if you have FFR of more than 0.8, it is okay to defer that lesion and you do not pay the price. This actually has been seen with the FAME trial, and more importantly, that concept then went to the next level. And next level was the patients who had a multivessel disease but have a FFR of less than 0.8, and that was the FAME 2 trial with the primary investigator being Dr. De Bruin from Netherlands and William Ferron from Stanford, which presented the trial in TCT 2010. The concept was that does medical therapy really works even in patients with a significantly low FFR, which they defined as our practice is less than 0.8. And basically what did we find? That patients who are less than 0.8, they randomized the patients, 1600 plan was 1600 patients, randomized to PCI plus optimal medical therapy or optimal medical therapy alone, with the primary endpoint were the death, MI, or urgent unplanned hospitalization requiring urgent revascularization, with the secondary endpoint of the cost effectiveness and anginal symptoms and the non-target, non-urgent revascularization and so. And therefore, I can say that from interventional perspective, finally we have a trial where PCI won over the optimal medical therapy, because this trial was stopped on January 22nd by the Data Safety Monitoring Board of the FAME 2 trial after they analyzed half of these patients with their average about 10 months follow-up, that patients who were randomized into the PCI arm had a lower MACE. That patient, patient has significantly higher MACE in the optimal medical therapy group, and PCI patients have a lower MACE, and largely driven by unplanned hospitalization requiring urgent revascularization. But whatever it is, finally we understood that there is a concept and really makes sense that FFR, incorporating FFR in our routine practice makes sense to improve the overall patient's outcome, and whether you do it or you defer it based on 0.8 really makes sense.
Excellent review. I have a few comments and several questions have also come up.
So we can answer those questions while Anu is still getting ready.
Yes, Anu, you want to give us a status update there? What's happening?
I think we'll wait a little more. We can answer some questions meanwhile.
So, the first question I have is that this is exactly the direction the live cases have been doing. Almost 3 years doing this, and your left main approach is exactly what has now been become a part of the recommendation, that all through we had a feeling that it is the one with the high syntax score which needs to be avoided.
Absolutely.
The other question I have for you is, how many progress wires have you used?
Actually, the progress which is between the 120, 140, 200, we have been using quite a lot, and as a part of expert CTO, that is the wire that we need to try other than the pilot wire. So, it's with our experience, yes, in especially angulated calcified CTOs, it's because, as I told you, because of that coating they have, it does go through these lesions very easily, and since the penetration power is high in calcific lesions, they are good. Only one thing that I have seen is, since we do this multiple turns and all that, a couple of times the tip has actually been disconnected from the wire. So you just have to be very careful when you are using this wire, unlike the confianzas and all that, that you have to be careful when you are doing multiple corkscrew movement in this with this wire.
So I think this wire is more for a penetration rather than the other techniques, the drilling and so.
Samin, at what stage of the training of the fellows do you let them start handling CTOs?
Yeah, well, actually, that's a very good point. I would say after the first, why the pressure went down? That after the,
actually, in the second part of the fellowship, simple CTOs, they actually, I think we let them do with some of these non-aggressive wires, but by the end of the fellowship, they are comfortable using most of these wires themselves.
Excellent. At this stage, I also want to welcome and thank a few very prominent physicians in the Middle East, Dr. Abdullah Shaheb and Dr. Wael Abdul Rahman Mahmood. They provided some exceedingly useful feedback about the live cases, and I want to thank both of them and continue urging them to stay involved, include your fellows in watching the shows, and please keep answering any questions that you may have.
Yes. Yeah, there we had a little difficulty in going antegrade, so the goal now will be try to go through the retrograde collaterals.
Yeah.
So Samin, you have gone through your algorithm which you had presented and giving antegrade a good enough try?
Yes. Yeah, I would know, but I think they will continue that part. But it's it's clearly the one of the major issue comes already in these cases that when you start seeing some dissections and many other things, that you need to stop and go give it a second try. Stop the angiomax many times when you have the small wire perforations. So that is actually was noted in this case, and wait few minutes, and that is what basically then you go on further.
Look, irrespective of the success of the case, I think the teaching value of this kind of a case is very obvious. And the strategies which you have mentioned, the different guide wires as well as your strategy, how you proceed on are right on.
Right.
I'm trying to see which is a good septal that we can try to get into if you are trying through the retrograde.
And you're going to stay off any of the epicardial ones.
Right.
Yeah, means if you see that's a big septal, if the angiogram playing, I'm looking in usually epicranial RAO view, straight RAO gives us a good idea which is the septal and which septal actually is connected to the RCA. In the RAO view, we're not able to see it well. So if I can go, if you see it here, if you see the straight RAO, you see the fanning. So many times what you can do is go through one of these septal. Once you reach there, then you inject through your catheter and see if this septal actually has any connection to the PDA. So,
Samin, you have several Japanese physicians visiting your lab and you spend a lot of time there. What are the Japanese doing better than us? Just more experience or more perseverance?
I would say more perseverance. That basically is, boils down to, and then same. They're not afraid of little tamponade and so put a pigtail and continue working. And sometimes they'll bring the case next day, and we started the procedure at 8 a.m. Could not go through by 4 p.m. Then bring back next day again.
And they don't have to deal with getting an HMO to say that they can proceed.
That's it. That's the key. And more importantly, knowing that the time is less of a factor for them, so that even they allow them to continue for a longer period of time. Over here, if that happens, I mean, it will disrupt your schedule completely.
So what is your cutoff point, Samin? How much stride would you give? How much fluoro time? How much dye before you give up?
I think very important is more than the time, probably the dye. When you have crossed more than 300, 350 and a fluoro time for more than an hour, you should say maybe you should bring the patient back or
this is exactly
time
the
to
difference.
stop.
You cited
Yeah.
1 hour.
I think whether 60 minutes or 100 minutes, to me, I think the first time making 60 minutes is reasonable, but many times you have to abort the procedure if the patient has some complication, so that maybe sooner. But if nothing is happening, that the 60 minutes or I actually go usually with the triple digit. If the fluoro time is 100, that clearly is a call for stopping it, or your contrast volume is the same. The more than 5 milligram per kilogram, so that anywhere you got to about 400, 500 range, clearly that you stop at that point also.
A Japanese colleague helped me understand why they choose 120 minutes. He said, look, it takes them 2 hours to make a Toyota on a Japanese assembly line. He says we should not be taking more to do a CTO.
That makes sense. Now, keep talking what you are doing now.
So now, if you can see there, right? Can you, yeah, angiogram wise. So I actually went, if you see, I have the Corsair, and like I told you, the wire of choice in this particular is Fielder FC. Just to go over what is Fielder FC, exactly like the regular Fielder, it is it's a glide wire with a hydrophilic coating, as well as it has a glide coat. So with these double things, it can slip, and Fielder FC not tapered, but since the tip weight is smaller, it is able to go through all these branches of the septals very easily. I think I am somewhere in one particular part of the septal. Before I know where exactly I am going to go, you got to take this wire, give some dye, and see whether we are in the right part of the branch.
Anu, 7 French guide there?
We have a 6 French actually.
Okay. Do you often use the 6 or for CTOs?
We use mostly 6 French.
Okay.
Yeah, actually that's another difference with the Japanese. They usually 7 or 8 French guides, because they rely quite a bit on the guide support. But we rarely use it. I mean, clearly, particularly I can tell you this large bore guide in the right coronary artery. Even we have seen Japanese doing the live cases. So many times you get that stasis and slow flow because it just causes spasm at the tip.
Samin, as you continue with the CTO, I'd like to also congratulate you and Dr. Prakash Krishnan, another landmark happening through the Miami Heart website tomorrow. You're starting the peripheral broadcast.
Yes.
And that is going to be the same time, 8 o'clock tomorrow.
Yeah, actually not tomorrow. It will be week after. What we have done is, yeah, it's tomorrow.
There appears to be a correction. It is tomorrow morning.
Fourth Wednesday.
Fourth Wednesday.
Oh, happened to be the fourth Wednesday.
Yes, tomorrow.
So that does turn out to be tomorrow.
All right, good.
And once again, that is info@ccclivecases.org if you have any questions on that. Anu, a little sub-intimal passage there?
Same, I think, the small septals, pay no attention, go to another septal.
Okay.
Yeah.
How's the patient in the meantime?
Patient
So
is
far
fine.
so good.
Wonderful.
No key changes, good
Look,
blood pressure.
That is so important to illustrate. This is where I think people with less experience tend to get a little timid and move off. Samin, how often are you getting CTOs that have failed at other institutions being referred to you?
Yeah, I would say that about 10% of the CTOs which we do have been tried somewhere and then they come here. Now, we also learned that the routine booking of those CTOs, like you did a subtotal LAD for acute coronary syndrome, but RCA was total. Those cases we used to bring them back in the past. No longer you can justify based on the OCC criteria of a PCI now. So you need to do the stress test on those cases. If ischemic or symptomatic, then only they come. So therefore, as I said, that there has been a lot of criticism about the appropriateness criteria, but at least they give you some guideline that where to do and what to do with these cases. And therefore, the routine patient with the, in the past 3+ years ago, we used to detect the CTO RCA, like this particular case would have been, and you did a LED PCI or circumflex PCI, 90% for ACS. We used to book them for stage intervention of the RCA. But we also learned that now that's absolutely inappropriate. So if only reason would be for you to bring those cases will be that if you have patient continues to be symptomatic, or you are documented intermediate or more ischemia, not a mild ischemia, intermediate or more ischemia on maximum medical therapy of 2 anti-anginals, which is the beta blocker, calcium blocker, the renologine or nitrates. So any one of them. So these will be required before you can bring that patient back for intervention. Therefore, no longer routine. The very, very important, and that's where the guidelines are, because everybody could say, well, based on the data, we know that it will be that CTO should be open. But yes, but those are all registry data. Sorry, the only question comes is that only if in a randomized trial, and we still have to have a randomized trial for the CTOs, that you identify a CTO. Some cases you leave it alone or you do a PCI. We know once you decided doing a PCI of the CTO, you succeed versus not succeed is totally different ball game. Success decrease, successful procedure decrease overall event rate. But if you are not successful, then of course you have higher event rate. But the issue comes that if you did not do anything, the goal should be the PCI versus medical therapy. You know, the kind of the old trial concept, that if should you routinely do a PCI of the totally occluded vessel. Now, right now we actually have a technique issued in the trial of the CTO called CTO expert CTO. They're basically trying to come up with the success rate in this day and age of the CTO, sponsored by Abbott. Sinai, of course, Anu is one of the lead investigator in the trial, and that will just answer that what is our various strategy for CTO. It's not a randomization. So basically, we still need to have, and this is where the editorial came, that it's a time for randomization of the CTO cases, that patients with a large vessel, I believe that there is enough room or the data need to be shown that patients with a large vessel CTO, irrespective of the symptoms, or let's say by revascularization of the ischemia, that should you revascularize them? And that question remains still unanswered, and so far we have no data to support that concept.
Samin, I'll take a quick question which has been here. It is Dr. Oliver Boissier asking from the Philippines. He says this is the first time he's watching it, he likes it. And can we show the hemodynamic monitoring as a video inset, especially where it is involving left mains and impella? Of course, that is not the case, and we always try to demonstrate that as a video inset. Anu, progress, what is your strategy?
No, we are just trying to get into any of those septals. It's looks like a major septal, but no wires are getting.
Yeah.
Okay.
The hemodynamic, go
yes.
back to hemodynamic again.
Oliver, here it is for you, the hemodynamics as you've requested. We do, of course, keep showing it. Anu, go ahead. What were you saying?
No, means difficult to get into any significant septal here.
Right. Look, I have always CTOs to do over a live case is always tricky. They require much more time.
But you know what happened is that we got so many requests because a lot of our audience have given us the input that they have learned a lot in the left main, calcific, bifurcations, and so they need to know few things, need to learn more. One was the CTO, second was vein graft, and huge management of the thrombus, slow flow, and so. So therefore, and of course radial also we have already shown. So they are all happy with what we have shown in terms of the teaching, didactic discussion in the slides, as well as the technique. Therefore, our goal is now, next 5-6 of our webcast, concentrate on these particular cases. With the vein graft, with total occlusion, antegrade or retrograde, we know some of them will be disappointing. And coming back to the point of the 31 cases which we had done until last month, if you recall, only one patient was unsuccessful, and that patient was a CTO, was done last year in actually year before in March of 2010. So that one was unsuccessful, and then that case after 10 weeks we brought in a live symposium of the June, and we succeeded that time. So although it was at time 0, as we mentioned that many of these cases will be unsuccessful at time 0, but then when you bring them back, your success rate goes up. So that we showed in the live that we have been unsuccessful in our CCC live, and we did it during live symposium and successful. So just to coming back to the point, yes, it's a challenging, but we need to go to the next level, and not be afraid of your outcomes, that you need to just go further, whatever the best can be show, good or bad or ugly, in many of these tough cases. And that's basically our goal will be, that not to be afraid of the outcomes, and of course these are the cases when they are come to your routine regular day-to-day life, that how you will manage them, and that will continue to be the fact.
We are able to find the septal, and we have reached the distal RCA now. If you can see this particular angiogram.
Anu, does the
you can see that.
Yeah, I see that, but at what stage would you be concerned with the dissection and the flow which you are seeing coming from the distal, I imagine that is coming from the septal, no?
Yeah.
One of the septal.
Right.
Therefore, angiomax is off right now?
No, we don't have it off. ACT has been on the low side.
Okay.
Now this is the most challenging part, is this one, to see, though we have got the wire into the
distal RCA,
epicardial part of the RCA, whether what we actually, now here this is another important point, that you don't use any kind of your transit catheters. You have to use Corsair. So you have the Corsair in the left main, LAD, septal, and going down. Also what you have to do, this is an important point in the sense that when you are doing this, you can, since your guide catheter can get sucked into the LAD to the septal and all that, in this patient is different, he has bypass, but this is the time that you can see EKG ST elevation from your contralateral vessel.
Yeah, the guide sucking, they have to be very, very careful with the guides, that in these particularly retrograde, when you try to advance back and forth, that you may have a trouble with the guide sucking in and so, and that actually very nicely this month the CCR, our JACC intervention, talking about various steps of this retrograde recanalization, and lot of emphasis on the guide catheter position, guide catheter pushing it. Yeah, there is a stent. Actually, part of that has been a problem that Corsair able to go down, is there is a stent in the ostial septal. So that's where we put a stent, and they actually have been shown also that if you have a if you have put a stent, you don't do a retrograde via those channels. But in this case, I think we are having issues because Antegrade, and just coming back to your point that you see a lot of clouds, as long as hemodynamic remains stable, many times we just stop the bivalvular for 20 minutes and so.
Look, which is exactly what I think the observation of the physician from the Philippines was. He was probably wanting to see the hemodynamics.
Yes.
I mean, another question which we've kind of answered, but it's coming from the lovely city of Belo Horizonte in Brazil from Dr. Marco Castanha. Which guide wire are you using to approach the RCA through the septal, and are you using a balloon as a guide wire support? I think Anu answered both of them.
Now the interesting question, the usual mentioned wires that which I told you, I had tried the Fielder FC, did not help me. I used the Whisper now instead with this particular, did not help me. What actually helped me cross was run through. And why did I try run through? If you see in your original picture, the septal is a big septal. If you see here, the septal that I used is a big septal. Even the major branch, the first branch of the septal is huge. When you have a big branch like that, many times these glide wires actually are unable to get into if they are a bigger size branch. So run through, I was able to get through and is already in the distal RCA. But the usual trouble because of the stent there, the Corsair is not making the turn anymore.
Yeah, no, but in that case, should you go with a 1.25 balloon? We have the
and do what?
1.25 over the wire balloon.
And then?
Yeah, so that will help because
No,
clearly.
no, I think we are getting stuck here.
Yeah.
It's nothing to do here.
No, but the 1.25 balloon might help because clearly the Corsair as
So
a
it's the
channel
same,
dilator.
you can do.
Samin, another question for either you or Anu. Have you done CTO intervention via bilateral transradials? Should I ask Tejas Patel in India?
Yeah, that's it. The people have shown those, but we have not done ourselves. But yes, the people have done it. Those who are radial fanatics, and so yes, make a sense to use the radial, but it will be the same issue with the guide support, and so will be a little more difficult.
I also saw, watched.
Take this. Dark. Give me the dark.
Samin, I have also observed a very.
Or you exchange length wire first? No.
Oh, cannot. Go.
Yep. Yeah, I'm sorry. Yes.
I have observed a very fine maneuver. I don't know if our viewers did that. That you moved on to the left and the fellow moved to the right. I think this is exactly what needs to be done in difficult, complicated cases. CTOs will require the combined expertise and intellect of experienced operators. And to me, as I have watched this case, I clearly see this as one of our best cases because of the techniques you've demonstrated. I think irrespective whether you have a successful case or not, the teaching value of this case remains paramount. Once again, I hope the Chinese viewers are able to click on the link to the Chinese simulcast on the main page of our website. This is again session number 32 from the Mount Sinai broadcast studios. What are you trying to do? So, I mean, one of the ways to gauge the interest of the live audience is the number of questions which have been coming to us today.
Absolutely.
Okay.
Okay, now
what we got to do is, how are we going to take this over the wire system? Use a dark wire. You take it out, and there's two ways. Either we're saying, I think the stent is not letting any device make a turn from the LED septal area for it to go further down. So, but still, I think we can use a transit catheter, fine cross, and see if that will make a turn. Because
no, I would go with a small balloon. No, the fine cross will not make. Here, right now, you need to go to a 1.25 EM over the wire or no?
Yeah, 125 sprinter.
Okay.
Over the wire?
No 1.25?
No, why you want that?
Okay, you want to get 1.25? See if we can get 1.25.
You mean monorail or over the wire?
Right now monorail. That's okay. Because you need to create a sub-intimal space, otherwise we'll go with a 1.5 over the wire balloon. But 1.25 having a lowest profile, actually in the outside there you even have 1.2 balloon we have 1.2 also.
Why don't we try fine cross and see if it will go down? No?
Try this one first. Yeah, we are just trying 1.2. I know we are reaching our time. This case probably will take another hour.
Right. Well, I don't think we have any restriction as to how much we'll continue to do it till you make some success, or we have a very defined strategy as to what to be should be done later, which I think is more important. But a remarkable teaching case. I think the discussion which you had just now as to whether to go with the parallel wire or to proceed with the small balloon is the value of this case. And this is exactly what Anu was feeling, and this is what you had felt that it will go. So let's see.
Put the guide a little bit in.
So for those of you joining us little later, a long, almost a 15-year-old CTO with demonstrable ischemia. Previous attempts of having done a septal, the patient continues to have significant chest pain. We gave it a shot with the antegrade, didn't work through, and now we are proceeding retrograde.
Take a deep breath.
Many times when you have the issue, to take a deep breath with the patient, both the physician and the patient.
Yes, I think the physician is the more important one.
Okay, get us a guideline.
So Anu, we are back to what you had felt may be the way to go.
I think what we do is use the guide liner. See if the guide liner will channel us into up to the septal area, then try other things. What is that?
Yeah, guideline.
Sameer, my thoughts today also went to a live demonstration case I did in 1999 at the Singapore Live using a Prima wire. And the most fertile memory I have of that case is the wire has so much strength and the case is short. Either you're going to go through or you'll perforate.
Yeah, that is true. We actually have the Prima and they used a part of that in the peripherals and so. We have not been much. There is some data that maybe it works very well in the
periphery.
In cases with the even thrombotic lesion and but total alone in the CTOs has worked out in the peripheries. This balloon.
Yeah, some long SFA occlusions, and I am sure Prakash Krishnan is waiting restlessly to discuss that with you soon.
Try this again.
This one?
Yeah.
And what? Dilate it there?
Yeah, dilate. The question what we have done now to give additional support brought a guide liner to the ostium of that septal.
But the biggest problem is the stent, I think. Stent is
so the mother and daughter support system.
Yes.
Okay, let's see if that you're going to try to advance that a little further, no?
Yeah. And key is that you advance it on your device.
Right.
Many times you may not be able to do it by itself. So that what you do is you first advance your balloon or stent when you're using a guide liner, and then on those you advance the guide liner further to make a further movement.
Deep breath.
Clearly, a lot of things have been happened just because of that ostial, the stent in the septal.
Yeah. Samin, would it have helped to explore that with IVUS to see what's happening with that stent, although I'm sure that would never
No, but
pass.
it's just the stent. No, remember even Japanese do say also, when you're trying the retrograde, don't go through the stents. Because that's the same. Because the overall, the resistance it creates with the devices and so, that you're not able to push adequately. How bad is the further side? We can show it and end it for next time. Yeah.
We can actually try again that side.
Yeah. Good. Let's see a little bit.
This is no good. Not making it.
So Anu, what are the next options going through in your mind?
Now I think we can still try whether a fine cross may go or may not go. Now what is happening, see how the wire is. You see the body of this wire is going and hitting against the stent. That's why I'm trying various maneuver, pulling the guide back, deep breath to see if that wire can come.
There is no possibility that the wire could have gone through the struts, could it?
No. We were able to get the corsair all the way down.
Absolutely, you're right. I did.
Yeah. Corsair went down, balloon went down. Right now with the guide liner, I don't see any further movement.
Any further improvement? Okay.
Yeah. So what we do? That's what
No.
Yeah. Therefore, now decide what's your next move.
Get us the, let's try corsair. Give the corsair.
No, corsair will not go with this now.
We can try. Okay.
Corsair will not go. Now
side.
question is the over the wire. That do you want to get any different over the wire system right now?
No, it's the same. If it's something we have to try, will be fine cross.
Good. Let's get a fine cross.
No, it's not going to go.
Yeah. Now even.
See, the wire is coming out.
Yeah. Okay.
Anu, your concept here with the fine cross would be almost like a buddy wire to give you more
No,
support?
the thing is, our goal is we have to get some over the wire system into the distal RCA through the septal. Then we change to some stiffer wire to make so that we can get through the retrograde portion of the cap.
Yeah. Now
that is a goal.
Yeah, exactly.
So, but where is this wire? I think we are sometimes,
I don't think you've lost the position. It
Yeah,
looks
no,
to be
wire is
exactly the
good.
same
No,
Now
wire is
question
good.
is
The question, did it go through?
Enough, go to the retrograde.
distal, yeah.
Yeah, that, do the LED.
RCA.
RCA, do the RCA.
RCA
Yeah.
picture.
That means that remember now we need to create that sub-intimal space, a
Yeah.
little more.
Yeah.
That's okay. This is the classical, your knuckle wire,
Maneuver,
retrograde, either you can do a balloon, but we are not able to get a balloon there. And that's exactly that knuckle has been suggested for this purpose.
Can the wire go further? No, cannot.
No,
just make sure.
wire will stop here.
You know, if you were to sit back today and review this case, almost every strategy which had been recommended has been demonstrated.
That's a 125 balloon, right?
Yeah.
Guideliner is not supposed to.
No. Okay, good. Then go with your any other next wire, and then we'll see. Just see.
No, I still
over the wire
think
system.
let's try Corsair now or no? Okay, try fine cross, right? Which one?
Okay.
No.
Try
No,
Corsair.
Fine cross.
Let's go Corsair.
Fine cross you have. What is that? 151. What's that? Over the wire? That's the same thing. What was that?
No, we used 1.6 Sprinter, right?
Yeah, that's a monorail though.
Yeah.
They're saying
It's
over
a
the
monorail?
wire. Will go? Okay, give me. Let's try fine cross first.
Okay.
Oh, you mean that one? Okay, give. Because if there is, then we can dilate it.
Yeah.
We are just trying a over the wire balloon to see if that can go.
Right, which is what you have been wanting to use.
Yeah,
all
now
this
the
time.
other question also comes since one of the negative point right now would be because we went with the 6 French and with the guideliner, Corsair and a wire will be a tight fit.
Yes, which is why
With
I
the
had,
guideliner. Yeah, if it was
I
7
had
French,
felt a
would have
7
been,
French would
we
have
were
been
very
ROV,
good.
because there's not a.
Now the
That
thing
now.
is same. This is over the wire balloon and we have our short 180 wire. So when we are doing that, just make sure you are able to see your movement here. So I have my guideliner. I'm holding the guideliner with my 2 fingers on the Y connector and just keep advancing, keep checking the monitor. So usually when it's at the foot end, the wire, you see an exit of the wire. When the balloon reaches the foot of the patient. Do you see the wire?
Excellent demonstration again, and we always tend to
All right.
compliment you.
Yeah,
I'd like
now
to
we have the wire.
Yep.
compliment the photographer here to get it exactly right in the.
Yes.
Okay, Pablo.
Yeah. Yeah. No, but now advance the Corsair a little bit. I mean, our guideliner. Sorry.
I think it's getting stuck with the stent.
Yeah.
Yeah.
That's fine.
So the guideliner is exactly at the origin of the stent.
Yep. Let's go with that.
Wire. Go further.
So 2 of the best hands in interventional cardiology, using all their skills and expertise, struggling with this CTO.
Don't dilate.
Rupture.
Yeah. Yeah. Although you can do a soft dilatation here of the septal branch.
Too proximal though.
Yeah. At this, because this is a 1.5,
1, 2.
1.6 Sprinter over the wire.
What would you achieve by dilating here? You think that will help you further advance?
Right. I think right now our balloon is not able to go further. The question is, with the low pressure dilatation, of course, you can have issues in terms of septal rupture and so.
Yeah,
But that is why this channel dilator actually has totally revolutionized the technique of our retrograde. That you just dilate, go, right? I mean, otherwise we have to abort now and bring back a few weeks later. I think it's the same way. The February few years ago, we had unsuccessful, and then June we made it successful. So we can talk about this case bringing back in June.
Other thing is we can still try antegrade again now that we have the wire there.
Okay.
Yes.
The other question is, quickly we can try antegrade.
Anu, right through the beginning of the case, in one of your slides, as well as Samin, you had mentioned exactly switching back and forth with both the techniques.
Good. Now go. Let's go forward with the balloon more. We're trying a little more with the balloon. Let's see if
Deep
that
breath,
makes
sir.
sense.
Deep breath.
No. Okay.
The wire I think was there.
Yeah. Wire is still there. You want to try the antegrade your equipment? You are ready with the what do you need?
Wait, don't do anything.
Oh.
Leave it there. See, it's almost reaching there.
Yeah. So good. That's yeah, okay. Then
And
go to LAO view.
Okay. Good. Go.
No, but you'll not be able to push it.
Let's see.
We need to go antegrade now.
Yeah.
Which wire you want to start there? We stop there.
Okay, let's take a picture. Now let's see how the left system had what we call as a cloud. And if you see, the cloud has disappeared now.
Completely disappeared and
so
probably ready to be given a shot again.
And see, the hemodynamics is all good.
Sameen, another lots of international viewers today. Somebody's asking, is once you have crossed, is IVUS a part of your protocol?
No.
Actually, no. You know, very interesting that IVUS, as you saw, even in that algorithm which was presented, that IVUS, they kept it even after retrograde, because for you to use a IVUS and then able to have a luminal re-entry require a lot of expertise. So that IVUS-guided CTO recanalization is still below your retrograde. So the IVUS is but tricky, need to understand where you need to make a hole. Until we have some balloon or wire which has the IVUS incorporated, may be a different issue. But short of that, I think the IVUS is not much helpful at present.
Sameen, with all these different new wires available to you, which angiographic predictor do you still think is the most perfectly correlated with being unsuccessful?
I would say calcium, calcified blunt tip.
Angulated calcified lesion.
Yeah.
All right, just
And
about.
I think everything else we can overcome, side branches and all that. But once you have a heavy calcium, or none of these wires, actually the penetration power of even your progress 200 is nothing when you have heavy calcium.
Yeah.
So Anu, what wire would you now, are you going to increase your penetration power going in antegrade?
I have tried all the penetration power here.
How, to what level
So
of
now
the progress wires did you go to?
I went to 200.
Okay.
Question, can we, maybe we change the way the angle it is. No, they give us a new, right? Give me the 12, confidence at 12. Yeah. The fielder, regular fielder. So I will use a fielder to go up to that area, and then it's the most challenging part here is the same. Where do you make your hole?
Right. The drilling.
Yeah. You know what? Give me Miracle 6. Miracle 6.
So would you, when you're going back antegrade, would you intuitively tend to use different wires this time around?
Yeah, yeah. I think what I'll do is I never used Miracle 6, but the same. There is like, I think with our multiple poking and all that, you can see like a lip that has happened there. We'll try to see.
Yeah, you may be able to break through the cap there. It's
Yeah, I think that's the best chance in my opinion.
Right.
Your retrograde, we have tried everything, and there's a retrograde success.
I'm telling you, yeah. All is the stent.
as the biggest.
And one of them, which is a jack intervention 1.5 years ago by Rathod, when from Japanese experience and so said that your angle of the collateral coming out, like in this particular case you see, when you are trying to go retrograde, that this the angle of the collateral is a very important predictor of unsuccess. So rather than going vertical down, that if you have angulated, that is what has been shown as one of the unsuccessful.
But I think here the stent is not letting anything go further down.
Yeah, here is
nothing.
further complicated with that point.
So how would, if you were to bring this patient back, how would
think,
that be different?
No, that will not change. But antegrade, I think you can always
you have a better
sometimes.
chance.
Yeah.
Okay.
See, now you are in that lip.
Keep going.
Broad based. You have the Miracle now.
Make a curve quickly.
Now I think I never showed you earlier how you make a curve for this CTO wires. Although
you never told us.
yeah,
but we did see it.
the traditional teaching is you go through here, you come out.
Yeah,
you need a very short tip that you need to make. If you can see here, just a short tip, you make a bend like that, or the other way is just cannot be more than 2 millimeters, 1 to 2 millimeters.
Well-trained
If you can see it.
Well-trained fellows and a well-trained photographer. We see it beautifully.
Yes.
So I think the needle, going into the needle and making a little bend is easier.
It is easier, but it can make the coils could be destroyed when you are doing that. You just have to be very careful.
All right, therefore, coming back to the strategy, we are going antegrade. We give few minutes, and if we are not successful, we stop here and then bring back a patient as our plan, part 2, at a later date.
Samin, take me through the strategy. How does that happen? When would you send the patient home? When would you bring him back? What would you keep him on antiplatelets? What would you do different to prepare him?
Well, I mean, very important, because you have punctured both of them. These cases, even they are unsuccessful, all the patients, as I mentioned, come with the great hopes that you still, they had to keep them overnight, knowing that you have perforated many of these small vessels, so that's better also to keep overnight and then discharge next day.
Is doing a echo overkill?
No, I mean, echo based, if there is something there, if you are still concerned and so that you do an echo, but otherwise, you know, and doing an echo is no harm, because small effusion, even if they show, you know, we know that we are not going to do anything to that anyway. But echo is okay, but usually we don't do unless we see there is some potential of clear, there was a fluid accumulation and so. In those cases, we'll do echo. Now, patient goes home, and then now this patient comes back about 8 weeks later. The now question comes is, he comes back in May, or we bring it back again for our June symposium, and that we need to decide.
Samin, what do you do with the antiplatelets?
Yeah, no, now since we have put a DES in this ostial septal, so and there's the Zymes there, so I'll continue same baby aspirin and clopidogrel 75 milligram he's on. If, let's say, the patient did not have a stent before, then in that case, and patient did not, you are unsuccessful from PCI point of view, and there was no other reason for giving clopidogrel, that patient will go home only on aspirin. And also, I also say that patients, this more aggressive antiplatelet therapy of either whether we had ticagrelor or you know, or prasugrel, in these total occlusion cases, we need to still decide, because many times, because of this aggressive antiplatelet effect, it can affect the outcome, so that we try not to use those aggressive antiplatelet therapy and just use the clopidogrel.
I am also sure that one of the other concerns for doing patients like this is to...
You know what, that thing is, it is not letting us go to any other area. If we're going back to the same smoke.
Okay.
Do we have to try the whisper?
Not the whisper case.
No, means we have created some small channels, I think. Some dye in the RCA. So we keep going back and opening those small channels there. See that? Yeah. Unless we try to see if we can make a hole somewhere here, which is difficult. Give me the Confianza 12, last wire.
Yep. The last wire of the day.
Yeah.
Confianza 12.
Anu, how much dye has the patient received?
How much dye?
Stage?
With both of them?
180?
200.
200.
Okay.
So we are...
so everything within the limits here.
So far. And our total fluoroscopy time has been 59 minutes and 2 seconds.
Okay.
Samin, I also was mentioning that a lot of these patients really need a very sensitive and a kind discussion with them. It's very hard for some of them to agree to coming back again. This is also a difficult procedure, longer procedure for the patients.
And knowing that 30% of the time you will say that you did not succeed.
Right.
That is the biggest, to me, it's the biggest disappointment is that.
Right. Very different situation than our amazing successes which we have even in left mains.
Yeah, that's right.
But I mean, this is one of the most difficult CTOs that we have chosen.
I have, you chose a nice way to welcome
but the real
the
one,
Chinese.
I mean, the point
Some
is you have the little acute little dye. This is, whole purpose was that be honest in this our live webcast and give the tips. Now we also know that we'll be unsuccessful 30% of the time.
I'd like to also at this stage mention and re-emphasize that in almost 3 years of doing this, there has never been any case which needed any editing. It's all live as we see it, as you see it, and hopefully there have been many learning tips today also.
We have had a couple of perforations on some of the
die.
CTOs, which is perfectly fine, but that's same. The whole idea of is teaching that what can be our viewers can learn and use there in their practice.
Look, most of these CTOs, I think, even when they fail, are partial successes because you're setting up the stage to bringing them back with altered strategies. So this is Anu Confianza.
12.
It's a Confianza 12. It goes to that small branch which caused a little perforation earlier.
Before, yeah. So it's tracking exactly the same course. Little different there.
Huh?
No, that's
No.
not that.
Same
Some
thing.
die.
Slow. Because now at least that basically you want to kiss the wire. This wire goes and do a little kissing, then we are done.
Many
It's
more.
going sub-intimal, same. I think it's the angle that has
No,
been
sub-intimal is okay. The question is not going into the that it's going into some small branch.
Samin, in the meantime, there have been series of international questions. Most of them have been answered as to what are the next steps which we are going to take, how is the patient tolerating it, the amount of dye, all of those have been answered. And just I'm actually quite gladdened despite you're not having been able to cross it. Just the number of questions and the interest from the viewers is pointing to me that there is an enormous educational value to even cases which will not necessarily succeed right away.
I mean, this could have been a very good retrograde case. Look at the wire. Wire has come all the way up to the back point of
minus that stent.
Yeah, minus that stent. And we felt that maybe just putting a stent will be good enough with those collaterals, but sometimes it's not. Now, therefore, what will you do different next time?
Yes.
Next time it comes, I think we have to go the same, puncture both sides, use a different guide, maybe more aggressive guide of
French,
the
7 French.
Well, I don't know 7, but definitely AL 0.75.
Okay.
And the other question is maybe before here today, maybe dilate that ostial of that the stent
Right.
once again with a balloon. But definitely once you do those, we basically quit for today. Then we just have to bring it back at part 2 later on.
Look, I think those are perfectly acceptable strategies. The patient continues to do hemodynamically well. You have not used much dye.
Yeah.
I think this will create a smoke now. Yeah.
Then leave it. Take it out. Take your wire out. Let me try with my cross it 100. Good. No, don't go there.
Even with some of the best hands in the world, you see the concern. There would be a cloud. I'm not going to do it. Let me try something safer, a different strategy. And Anu, excellent illustration of your depth of thinking, using strategy, all the expertise in very difficult cases.
Take the wire
You
out.
want to try that?
Just, no, we are done. We just, I always try with the non-coated, cross it 100.
Okay.
Call it a Sharma's CTO wire.
Okay. you get one more shot, the final say in this, no problem at all.
Yeah. No, but those will be the strategy.
No,
but
it's also, algorithm is okay up to a
You have to
point,
pull
but
back the
25
pull
years
this
of
thing
doing this, I'm sure you sometimes go with your gut feeling.
yeah.
The crosset comes with the tip that is pre-made, and they usually look at the tip of the wire. They are bigger, maybe almost 5 millimeter.
I
curve they make.
want to at this stage once again thank Una Wong for her amazing translation. I want to continue welcoming our Chinese contingents and the delegations. Hopefully this case has been a precursor of many other excellent cases you'll see. Want to thank Dr. Abdullah Shehab, Dr. Wael Muhammad in the Middle East, and so many of you who have kept asking questions today.
Okay.
Whisper.
Little die.
Same channel, huh?
Yeah, keeps going.
Yeah,
to the same
keeps
channel.
going exactly into the same micro channel.
Yeah. The other question is that do we do a antegrade cart, bring a little balloon on the antegrade wire and create a subintimal space? Now, only question with that antegrade cart is that you have a high chance of perforation, and particularly you have already a little cloud earlier.
My
So that
intent, my
yeah.
intent would be to not use
Not
it.
to do an antegrade cart at this time.
We should not here because it is definitely outside the vessel wall.
Yeah.
At where it's making an exit, not exit, the entry.
Samin, if I was to make you a recommendation here, this is a great case for the June symposium.
Yeah. And then but same, the June symposium and July we show the case with the history
live follow-up.
saying that history repeating itself. Yep. Okay. Therefore, now if we complete again, as I said that the total occlusions, we can go back to the slide.
Whisper, right?
Yeah.
The whisper.
Samin, I want to have you, yes, please take us through this slide, and then I want Anu to finish off the case by telling me what has she learned in this particular case.
Right. So basically just the recanalization of the CTO lesion should be undertaken for appropriate indication after careful planning and using antegrade technique, and if fails, then try retrograde technique to improve overall success, although in this case, both have been tried and not been successful. 2012 OCC focused update continues to provide key guidance to interventionalists for appropriate selection of treatment strategy. No PCI, or many of those cases where there is PCI of the most CAD lesions, or CABG for complex CAD with high syntax score. And also we learned that the physiological FFR-guided PCI of significant lesion with the FFR of less than 0.8 has proven to be superior to optimal medical therapy alone. And Anu, just make it the last one. So that
Anu,
we can
what have you learned from this
Yeah.
case, and what would you be doing different next time?
I think the most important thing being having done so many CTOs that every CTO is not the same, and same the number of years. We have done CTOs, we have opened CTOs almost 20 years old also, but every CTO is not the same. If you see here, it was a short area, but we knew the biggest point here, since it was ectatic and very blunt end, we knew we were not able to get exactly where to enter to get into the lumen of the
Plus
CTO.
the presence of the stent, I think, which made the retrograde.
Otherwise, retrograde would have been the stent. I think they always say whenever there is stent, don't even try to do retrograde. This is the second retrograde with the stent where we could not get anything down. Is exactly where the stent is. You don't get your devices go further down. And for the next time, when he comes back, we'll try 7 French, use a guideliner all the way up to that particular area, and then do the same strategy with all these wires.
Samin, final last comments from you?
Yeah, but I think it's the challenging, and yes, a little disappointment is there, but overall I'm fine that there is no complication and not unexpected outcome with the goal and knowing that our history, that how these cases we have managed them with the stage intervention, that in next 3-4 months or so, I am very confident that we'll show this RCA open and with a good success.
With your determination, I have never doubted it. I hope our viewers have found this useful, very interesting, and once again, a welcome note to the Chinese viewers. Hopefully you have enjoyed and benefited from our Chinese simulcast. We'll be back next month, March 20th, for session 33. Till then, goodbye.